Now, there's a number of practical issues that come up, and I want to go through some of these practical issues of cooling because we'll inform some of our subsequent discussion. I want to give you a flavor for how we deal with this and how we think about it. Well, when patients are cooled, one question that comes up all the time by healthcare providers is how to cool. What are the methods we should use to cool patients? Another key question that always comes up is when to cool. You might imagine that you need to start cooling soon. After all, I shared with you the laboratory studies that showed that inflammation and mitochondrial problems and reactive oxygen species, these problems start right away. They start very soon. So you got to cool as soon as you can. We generally believe you need to start cooling within a few hours of a rest. So God forbid if one of your loved ones has a cardiac arrest and is resuscitated, God forbid they wait to cool till the next day. You really got to start cooling right away. Now, another question, of course, is how deep to cool. We generally believe between 32 and 34 degrees is the appropriate therapeutic target temperature based on those studies I shared with you. And then finally, how long to keep cool is an active question. If you recall, one study used 12 hours of cooling, another 24. So there's a lot of questions still that remain to be figured out about how to use hypothermia in practice. Each hospital tends to develop their own protocol, and there's a lot of different flavors of the way this therapy is implemented. And much more work needs to be done to bring our understanding to a unity. Now, I want to share with you a little bit about our initial experiences. When I started using hypothermia, I trained at the University of Chicago hospitals, and we started cooling as far back as 2003. Back then, there were not good tools to cool, meaning there wasn't a technology that we could use to steadily and reproducibly cool patients. So we did what we could do. We packed people in ice. It's what we had. Now, packing patients in ice, it's cheap. Every hospital has ice machines. And it's non-invasive. We're not sticking specialized equipment into patients to cool them. But there are some serious disadvantages with packing in ice, and we experienced this firsthand. It was messy, there were puddles on the floor, and patients don't like seeing their loved ones packed in ice. But perhaps most importantly, and here's some interesting science to share with you, there was no thermostatic control. You see, it turns out that 37 degrees is what is considered a normal set point for the brain. Our bodies defend a temperature of 37 degrees Celsius or 98.6 Fahrenheit if you like. 32 is not a natural set point for our body's thermostat. So to keep someone at 32 takes a bit of work. When you cool someone, their body tries to warm up. You have to cool some more. Sometimes you overdo it and sometimes you underdo it. So it's very messy when you use something that does not have a thermostat, we discovered. And we studied this, and we and a number of other hospitals pooled our data and looked at this. And what we found was overcooling when using simple ice cooling methods was a problem. We would overcool patients. And when you get patients too cold, there's more side effects from the cooling. So this is a problem. And I want to share with you one example from this study. The first author of this study, Raina Merchant. Dr. Merchant is a colleague of mine at the University of Pennsylvania and studies a number of things in cardiac arrest. What you see here is a patient, and the red lines represent 32 to 34 degrees Celsius. And you can readily see this patient is not staying within that target therapeutic range. This patient is getting too cold and too warm and too cold and too warm. We're taking ice off and putting it on. This is not a comfortable position for healthcare providers. This is what the situation was before the advent of cooling equipment that have thermostatic controls. And there's a number of vendors now that sell equipment to hospitals that allow for very careful control of body temperatures at non-physiologic set points, like 32 degrees Celsius, for example. Now, what about other methods? I get a lot of questions from providers in the field, from ambulance providers, people in EMS or emergency medical services, the technical term for ambulance healthcare providers. Now, ambulance providers have fluids, and they wonder, well, can we give IV fluids or intravenous cold saline solutions to lower body temperature? Many of you have had IVs and been given IV fluids. If IV fluids are cooled, could you cool a patient that way? Well, this has been looked at, and it's been found that you can cool people very effectively with cold fluids. And in this study, published in 2007, most of the patients cooled with fluids reached goal temperature very quickly. But just like ice, it was very hard to maintain it. Cold fluids has no thermostat, ice has no thermostat. So it's very hard to maintain a steady 32 to 34 degrees Celsius. So this is, again, a technical challenge when you don't use devices to cool. I want to turn to a real-world example now of a hospital that decided to use hypothermia, because I think we can learn a lot when we look at single hospitals' experiences with implementing new therapies. These are not randomized trials. These are not truly and technically scientific experiments, but much can be learned. And this was a hospital in Switzerland that decided that this was the right thing to do for patients, and they started cooling people after cardiac arrest. And they cooled people using ice bags and then a specialized cooling mattress. They chose a target temperature after arrest of 33 degrees, and they maintained this temperature for 24 hours after resuscitation. Now, what they did is they looked at survival before they implemented this new plan, this new protocol, and then they looked at survival with this cooling protocol in place. And here's what they found. I'm going to share with you their data in terms of something called Cerebral Performance Categories, or CPC scores. What does this mean? When a patient recovers from a serious life-threatening event and you worry about neurologic injury, you want to have a system of categorizing how healthy they are from a neurologic standpoint. All of you watching this today are probably a CPC 1. The CPC scores go from 1 to 5, 1 being normal neurologic function. You can walk, you can talk, you can eat, you can perform your activities of daily living. CPC of 5, which is the worst score, means brain death. Or in this case, you're going to see pooling of brain death and death information. Now, first, they looked at outcomes for patients who had out-of-hospital arrest, meaning arrest in the public sphere or at home, but not in the hospital, and had a VFib, or a shockable rhythm of arrest. Now, at baseline, these were the CPC scores. As is often the case with cardiac arrest, most patients did poorly. Some people had a CPC of 2 or 3, which reflects neurologic injury. So these patients are injured. They have some degree of brain dysfunction and brain injury following arrest. And a small fraction of people are CPC 1, which means they're fully functional. Now, that's not a very pretty picture. Most people are doing very poorly after cardiac arrest. That's what we find every day. Now, with cooling, they found a dramatic change. They greatly reduced death and brain death. They greatly increased their CPC 1 survival, meaning they're survivors with fully working brains. And also, interestingly, they reduced the number of people with serious brain injury. You see how CPC 3 has really plummeted, and even CPC 2 plus CPC 3 as a cohort has shrunk. What do I mean by that technical term? I mean that with cooling, people either do very well or they do very poorly, but it lessens brain injury. Now, an important point to take from these data I'm sharing with you today: hypothermia is not a magic cure. I'm not here to tell you that hypothermia is a magic bullet that will bring everyone back to life and health. Indeed, you see that even with cooling, many people do poorly. Many people die. This is a very serious condition, cardiac arrest. Hypothermia works statistically, meaning if you cool enough people, you will have many better survivors, but not, unfortunately, everyone. Now, at this hospital, they also decided to cool people with non-shockable rhythms. And I talked to you in the prior lecture about something called asystole. Asystole is a highly mortal cardiac rhythm. Asystole is flatlining, and you've heard in television shows flatlining, and perhaps you've seen the movie Flatliners. This is a term meaning there's no heart rhythm whatsoever. These people do very poorly, and before any cooling, you can see that most of these patients died. Some had brain injury and lived, but no one lived with no brain injury. Now, with the institution of a cooling protocol, they actually got some CPC1 survivors from asystolic cardiac arrest, meaning some people fully recuperated despite them being flatlined once they were cooled. This is a remarkable thing. And if any of you have seen the movie Flatliners, they actually use cooling in that movie to resuscitate patients. Very interesting. Now, hypothermia represents one aspect of what we call post-arrest care or post-resuscitation care, but it's not the only thing. Much of this lecture we've talked about hypothermia, but there are a number of other aspects that healthcare providers have to provide for patients. For example, many of these patients have very unstable blood pressures. Their hemodynamics are abnormal. So very careful attention has to be paid to this, and good critical care units have all sorts of invasive methods and other methods to measure blood pressure and measure blood flow. There's ways to combat brain swelling and combat low blood pressure, and these are important aspects. So these patients need to be in the intensive care unit. They're very sick for a number of days. Also, many patients have cardiac arrest from blockages in their coronary arteries. You may have heard of coronary atherosclerosis, or blockages in the coronary arteries. We talked about this a little bit in our opening lecture. Many patients of cardiac arrest need to go to the catheterization lab, the place where they do angioplasty or open these blockages in arteries. And they can do that while patients are being cooled. So there's a bit of a dance that goes on, a choreography where you cool people, they get angioplasty while cool, then they get rewarmed. And then finally, neurologists have to get involved. There's issues of brain and outcomes assessment, and neurologists have to help us understand whose brains are recovering and whose ones are not. Sometimes these patients develop seizures following cardiac arrest. That's a very important problem that we're working on currently in the year 2012 to understand better. And neurologists at hospitals are required to help us sort out these issues. So it's a very complicated business, and hypothermia is only one aspect of the necessary elements of care. If you want to learn more about this, we have a website devoted to hypothermia after cardiac arrest. There's a very long link on the screen there, but you don't need to know that link. If you Google Center for Resuscitation Science, or I should say if you do any web search, not necessarily Google, Center for Resuscitation Science, you can find us. And we have a web page where we have information on cooling, and we have a list of all the hospitals that we know of that provide hypothermia in the United States. And we have other interesting news articles. So feel free to go to the website. It's free. There are no ads. We make no money from this, but it's a community resource we've set up for you and healthcare providers. Now, speaking of healthcare providers, those of you who are critical care doctors or nurses, or emergency doctors or nurses, or EMS professionals who are listening to this today, we have a course that we run at Penn called the Hypothermia Training Institute. It's actually been renamed recently the Hypothermia and Resuscitation Training Institute because we want to focus on resuscitation as the core of this. The next course we're going to hold is in March 2013. What we've learned is this is a complicated business, providing hypothermia. It sounds simple, cooling people down, but it's not. And so we do an intensive 2-day boot camp. It's a CME course. For those who don't know what that means continuing medical education course, where we teach about hypothermia methods and protocols. And really this course is not designed for the lay public. It's designed for healthcare providers who want to be local champions in the provision of post-arrest care. And we offer certification methods so you can become certified in these techniques. And this has been very important because we need more hospitals to provide this therapy. Those of you who are listening at home, you should find out if your local hospitals provide hypothermia, because if your loved one has an arrest and ends up at that hospital, you're going to want to know if they can offer this therapy to recover the brain after cardiac arrest. One of the aspects of our course I think is so important is we keep the course small so it sells out. We used to hold it quarterly. It was too much work. Now we hold it twice a year. But I recommend if you're a healthcare provider, come check us out. I hope you've enjoyed this lecture on therapeutic hypothermia and post-resuscitation care. This concludes the third lecture in our series on resuscitation science. Please join us for lecture number 4, where my colleague Dr. David Gajewski, another emergency physician at the University of Pennsylvania, will be discussing some future concepts and exciting new directions for cardiac arrest care and resuscitation science. Then finally, in lecture 5 in this series, we will be discussing survivorship and end-of-life issues pertaining to resuscitation for both victims of cardiac arrest and their families. We hope you're enjoying this series on cardiac arrest and resuscitation science, and please join us for subsequent lectures. Thank you very much.